it's already been on Twitter somewhere, and then it's picked up on the news and something else. And this is a pattern of amplification that unfortunately has incredibly bad consequences for the people who are in this situation. And I unfortunately don't have a solution for that other than hoping that over time people calm down. And in the earlier days of this, in August and September, we were able to handle many suspect cases, people, children or adults with fever without any of this. And then unfortunately after the publicity really raged, it became much more challenging for us.
Great. Let's take another question. Yes. Here's a...
So my name is Judy Kuriansky, and I appreciate this panel so much, all of your contributions and the work with ICAP. I'm familiar with your work in Africa because we've overlapped with some of our projects in Lesotho and elsewhere. So I'm here wearing three hats, but wanting to ask ultimately a question about psychosocial programs from the perspective of one, I've been here at the Columbia community since 1967. And in 1980 did a lot of work about AIDS. We were calling it a phrase, which is related to that word there, fear. Then as a journalist, I have written and been a reporter for many years, and have been to Sierra Leone and done programs on the radio related to the dramas and the news shows, helping people understand. So I underscore the point about how radio is very crucial in communication. But most importantly, right now, I'm the chair of the Psychology Coalition at the United Nations. So I'm very aware of the issues that the UN is focusing on because this has calmed down in America, but very much a problem around the world. And so my question, since we are having two events about the psychosocial issues about this epidemic at the UN next Monday and next Thursday, about what the panel is aware of with regard to the psychosocial programming to address the fear.
Thank you.
Thank you.
Maybe we can get Jay. You might want to address this in terms of some of your community.
Yeah. So I mean, I would say that the approaches that we've had have been primarily focused on. There's a number of issues related to fear. I would say the first one is one that I talked about at the beginning, which is really about mass public communication. The second component of that is working directly with communities. In addition to the work that we have done with spiritual leaders and community groups who've also just done a tremendous number of talks using with elected officials and going out into communities and spreading as much information. You may see now there's a subway ad campaign as well that we're running as well about the facts. And so these are all part of our efforts to address the sort of psychological components of people. You know, we also have to worry about the people that we're monitoring. And so we also have in place sort of hotlines for people to call and provide them with information to provide psychosocial support. I think what's really unfortunate about this discussion about quarantine is that when you I read something in the paper, I don't know, a couple of weeks ago, I think it was a room for debate in the New York Times, and one of the people was basically saying how they couldn't understand why people wouldn't just be quarantined. How come they can't lock themselves up for 21 days? And they talk about it as if there is no downside to this, that there's only a benefit to the publication, but you can stay in your home and be in complete isolation. We know that doesn't work at Rikers, and we know that doesn't work, in your home. Isolation, cutting people off from the social network is probably one of the surest ways, other than forced insomnia, to kill somebody. And so, so we know that these methods, they may be necessary in certain circumstances, but only when done humanely. And I think that's really the challenge, is there really is no perception of it. So I think we're trying to address this on the large scale through the community organization and for people who are directly being monitored to provide psychosocial support, but I'm not sure that we have everything in place to overcome this. This is a very traumatizing experience for people, and particularly people, as the Imam explained, that have been through an experience that we're never going to be able to undo that. And I don't know what the long-term consequences are.
Because even right now in the labs, I have some materials in French, Spanish, and English. We give it at every prayer, what people comes in, give them those tools for them to be aware of this situation. So we're doing whatever we can do to inform people.
Yes, let's take a question, David. Yeah.
Thanks. Really interesting conversation.
Introduce yourself, David, please.
Sorry, I'm sorry, David, who said ICAP. I'm just wondering if there are any lesson. My impression is that change in ritual burial behaviors actually happen quite quickly, and in terms of reducing risk of transmission. And I just am curious if there's any thoughts about how sort of a rapid mass level public health response was able to be created without overly creating panic.
Emmanuel, do you want to talk about that?
Yeah, it's a very interesting question. It's a mixed picture.
It's a mix.
On the positive side, there's definitely been a lot of changes, and one of the things we've observed is that change has come best when it's been collaboratively worked out rather than imposed by government or by, literally, at the point of a bayonet. So when we've gone to say, listen, we have this problem, when you touch somebody who has Ebola, you are or who's died of it even more, you have a significant chance of getting it, what are we going to do about it? Rather than, one of the best questions I heard from somebody talking about doing community work is, the question is what are you going to do? Rather than because so much of the narrative that I think is deeply flawed and reflects a flawed one about sort of foreign aid is that it's all about what the foreigners are doing. And inadvertently, even well-meaning people are doing it because they say, we need more, we need more armies involvement. Why hasn't the New Zealand army been involved or whatever? And really you need to ask people, what are we going to do about burials? And there's definitely been changes. For example, there was for a while the people in Sierra Leone where, the government or the teams from the response were coming and getting people away. Some of them were reported to be drunk, to be openly disrespectful to bodies. So not only are you going against pretty basic tenets, but you're violating, even common sort of across all cultures. And possibly we have to have, empathy for the people doing that. They're probably traumatized. They were getting no psychosocial help. They were probably really, self-medicating with alcohol, but not a good situation. But if you go and say that, and people said, listen, we can do this. If you train people from our communities, we will bury them because we know that these young people from our communities won't be doing what these people we've never met before will do, and we'll know who's under the suit. So that's the good side. The bad side is that even now, we are seeing cases where health workers who are involved in the response, so people who know are burying their colleagues, other health workers who have died, and touching them directly. And I think the answer, as sort of frustrating as it may seem, is to listen more and to figure out how they're doing. And we're in the process of doing that. But we have to understand why somebody who has the facts, who's educated, still is choosing. And what we're hearing in our initial conversations is because it just seems so disrespectful to send someone to their grave without some form of ritual and cleaning. But and that's why, that's part of the reason why in Sierra Leone things aren't going so well. And we're I think it's stuff all of us in the room can work on.
I think it's also, we heard when we were in Sierra Leone is that they're doing some changes exactly to get around this, trying to provide more respect for the burial, like simple things like inviting the families to be present at the burial, for example, in the cemetery. They don't touch the body, but just having them be present, having actually the name of the individual on a plaque where they're buried, GPSing where the grave is located if they cannot be there. So I think there are attempts to try to, while you're changing the cultural norms, attempts to at least provide some respect. So the families hopefully will be more willing to accept the change. Yes.
I'm Marsha, infectious disease fellow I guess one of my questions that I've been following the news very closely throughout this, and I'm wondering, I guess, how much race plays a role sort of in the epidemic. I think in Africa there's a feeling that this did not hit the media until a white man was infected, and then also in talking about the HIV epidemic, that's mostly among Black MSM, and even coming up with the recent news in Ferguson and what's about to come to New York with the police brutality. I think those are all relevant in terms of how we talk about race and how we talk about epidemics that hasn't really been talked about a lot, actually. So just any thoughts on that?
Well, I think in some ways the slide I showed you, which showed the peak of interest that And we did another analysis where we looked at the Google. There's something you can do, Google, like if you Google something or another, and if you do that, you can actually, I don't know how to do this, but if you do, you can graph how many people have done it over time, and it's very interesting when you follow this, is that the peak is when there's a case in the United States. That's when the interest goes, and then it abruptly goes down. And obviously there are elements of race and foreignness and all of that implied in this. But maybe, I don't know, Gregg, do you want to tackle that?
It's obvious. I mean, we know that TB, HIV, Ebola, it's about race, but it's also about class and poverty, right? I was in Brazil last year trying to look at the difference between responses to HIV and TB and maternal child health, and one of the people who worked on the TB program said, 100 years ago when TB hit the middle class in Brazil, we had all these associations formed. And I said, so what's the difference now? He pointed up at the favela on the top of the hill and said, that's where TB is now. And so, that's, people think it's West Africa where Ebola is. It's HIV is, we have a raging HIV epidemic in the US. I'm on a college campus where when you talk global health, everybody thinks sub-Saharan Africa or somewhere else. The AIDS epidemic is not in the US. And so it's always somebody else. It's not in the ethnic, social, economic class that a lot of people in public health come from. And so these are diseases of poverty and diseases of race and discrimination and marginalization. And, Christie and Cuomo and Malloy, Northeastern governors who should know better, took this on because they knew that a lot of the people who were going to be most affected by this were not in the best position politically to speak back. And so, the response to it also was politicized, I think. And, shame on Governor Malloy and Governor Cuomo, who should have known better to do this to marginalized communities in this city, this state.
Thank you.
I think,
yes, Imam. Thank you.
in the Islamic perspective, when we come to race, there is a verse in the Quran in which Allah stated that all mankind, we created you from Adam and Eve, and we made you tribes and nation, and the most honorable within yourselves is the one who is connected to Almighty. So, my thing here is that when you see somebody judging others, because he put in his mind that he's so perfect, when you think that you are perfect, you will sit down and judge others. If we are creation of God, we're not perfect, we made a mistake. HIV, for me, is not an African thing. It's not a black thing, because it's there, it's everywhere. So we must ask ourselves, let us come together as a human being and as a human being to fight these diseases. We can do it if we come together, but sitting down and judging others because we're black and so we brought Ebola to America is not an issue here. So it's like even my country, there is no single case of Ebola in Cote d'Ivoire. But I always send a message to Ivorians, don't sit down and be happy because there is no single case. You never know. Sierra Leone, they are people, they are brothers, they are sisters. Liberia is the same thing. Guinea, because you have a Konate in Guinea and you have a Konate in Cote d'Ivoire and you have a Konate in Mali. So don't be happy. Whatever happening in Sierra Leone, Monrovia, Liberia, and Guinea is happening in Cote d'Ivoire. So don't be happy. Let us come together and fight this disease, this epidemic disease. We can do it because no one is better than anyone. We are same. Let's think like that and come together as one to fight. Yeah. I think if we do that, we will succeed.
Thank you. Emmanuel, you wanted to add something?
Just a quick comment. So, obviously race has a huge amount to do with it, but a couple of sort of caveats to that. One is, we have to remember it can work both ways. It's not just a unilateral, some people are better than others. I remember when I was in Peace Corps, when people had a seizure in the village, it was like there was mourning. And once there was a tourist, like 10 miles away, a tourist kid who had a seizure, and people told this story laughing, like in detail. And because it wasn't someone they identified with. It was some little French boy and so it was other. So I think it's a, human thing. I'm not saying it's right, but we have to view it. The other thing I would say is, so we can all agree it's wrong. We all, but we have to think about some of the feeder stuff that maybe we're implicated on. I think the fact, that the press, I totally agree with Imam Konate, has a huge role. Every time there's a story in the New York Times in which, 95% or 100% of the people quoted are sort of, white public health officials or European or American ones. Every time there's a story that, like, the heroes who come, who've gone and treated, forgetting the fact that when you're there, as with most public health activities, 99.9% of the people fighting Ebola, the people taking the most risks, are people from Liberia and Sierra Leone and Guinea. They're, like, invisible. And I'm sure the New York Times doesn't think of itself as racist, but they contribute to this notion that these are people who are victims and, somehow incapable, whereas in fact, now that we're seeing some reductions in Monrovia and Liberia, like, I know for a fact, for having seen it firsthand, that the overwhelming responsibility for that is because of incredibly effective people locally, often working with minimal support. But that's, like, invisible to the Western media. And they're doing it probably because their market, people want to see Kent Brantley. They don't want to see, Umaru Kone, who they've never heard of, who doesn't look like them. But the media, I think, has a big power to change that, and we have to kind of hold them accountable.
And you're right. I mean, it's unfortunate because we know that when there is success, we know who's going to take credit for it. So, and it's beginning to happen actually in Liberia by just very clearly and often the people who are really responsible for success will be forgotten. I want to actually come back to you, Emmanuel. I'm wondering over the past several months, with the issue around quarantining and the need to be locked at home or Rikers Island or whatever for 21 days, are you seeing less interest by volunteers or people to go and actually do the work in West Africa?
Yes, to some extent. I have to say, both on my own team and then the wider, I've really been amazed at how many people are saying, can't count me in, many more than not. So I think in some ways the biggest story is just how motivated the public health community has been. And we have, right now I have 4 members of my immediate team of 40 people in West Africa, and it's been a nonstop rotation. But this said, it's definitely dissuading people. So we've had the chance for, not always best reasons, but to work with the Department of Health, the New York City Department, which has been just amazing. Like, so on the right page, functional, sort of getting it, helping us to get appointments for getting a medical appointment for someone who's come back from West Africa, who has another problem, is, like the way of the Calvary. But they kind of know how to get things done. But we have had, I can think of at least I'm pretty confident of that number, at least 10 people who have opted not to go. It's hard, you can't read exactly into all the factors of a person's life or be in their mind, but there's no doubt that, the fact that they're going to be limited when they come back is a big part of it. We had a case of in the Department of Health, was just outstanding, of someone, who's been away for their family for 6 weeks. Again, someone who said, I know I'm needed, who had lived in West Africa, was very well positioned, and in fact did an amazing job there. And she comes back having chosen to be away from her kids for 6 weeks, and then she's given a choice between either quarantining herself from her kids or having her kids not attend school. Now, it didn't stand. Like the school was reason too, the Department of Health, put not pressure, but sort of gave the facts to them. But those kind of things, to answer your question, are definitely having an impact on our ability to send in. I very much agree with Gregg's point. Like, it impairs the Ebola response, but it also makes us wonder, like, if ever we have a really big public health problem, or an epidemic or some other one hitting the U.S., we are so not ready.
And I think it also has I think the other thing is what we've heard from some of the people who've returned is rather than them being acknowledged for their service and their courage, and they're not really welcomed with open arms, both figuratively and actually in reality. Let's take some more questions, a few more questions. You asked one already, right? But let's get somebody else and then we'll come back to you. Yes.
I'm from African Services Committee. So I think that I was just wondering if the response to Ebola has been proportionate really to the threat that it poses Americans here in the United States, as far as like funding and coverage. And speaking about that at the same time, I was wondering if this would be a good time kind of to address if our response to other conditions, like chronic conditions, is proportionate to the threat that they pose, the morbidity and mortality of these diseases to Americans, and not only Americans, but public health in general, worldwide public health.
Thank you. And I have to comment on Jay and the button, the big button he's wearing there, which says, can you see it in the back? What does it say, Jay?
Get your flu shot.
Get your flu shot. I got my flu shot last Friday. Can you, Jay, do you want to comment on kind of putting in perspective the threat versus the resources and so on?
No, this is absolutely a major concern that we have. Also, when you think about the investment of resources that we're placing into control of this compared with, we had one case of Ebola, there are over 10,000 cases in West Africa, and so, we had to do it right one time. Think about having to do it perfect 10,000 times, and you can understand the scale of the epidemic. So I think there's a number of questions about perspective. I mean, I think the challenge is really that until you understand social dynamics and how fear spreads to a population, you can't really understand the perspective of how much money needs to be spent on something. As I sort of mentioned at the beginning, I don't think we needed to do it this expensively from the perspective of controlling the disease. We certainly hadn't planned on that. But when the concern in the community was raised to such a level, we knew that we had to go above and beyond what we would normally dictate the evidence to do, because normally in our mind we're always calculating cost and benefit. Do you really need to do this compared with all the things you could do if you didn't do that, your opportunity cost? So I think the answer is really about no, as it relates to disease transmission. We don't need to invest as much as we have in the United States. But as it relates to restoring faith in government and understanding the role of public health, I think we really did have to. Unless there was some way to prevent all that, and I don't think there is a vaccine for fear and cynicism.
I think in some ways, Jay, I've thought, like, for example, because of the threat of Ebola, whether the Department of Health could actually utilize it as an opportunity to promote flu vaccination and pneumococcal vaccination.
So let me just
because in reality, both these vaccines are very underutilized.
And there's great credit to our mayor. He picked up on this very early on in our planning meetings and said, well, what can I do to get a message out there that people can do to help themselves? And he agreed with us on flu vaccination. And so we have actually seen a very dramatic increase in the proportion of adults getting flu vaccines. We have different ways of measuring it. But it's a very clear increase, and we'll see if it gets sustained over time as a result of this. And also really another component of this was restoring faith in public health systems, and also drawing attention to another huge problem in the United States and globally, which is infection control in healthcare facilities. Here in the United States, just in New York alone, we had an outbreak of measles in the spring, largely with exposures and transmissions occurring in healthcare facilities. So we've known for quite a long time here in the United States that we are not as well prepared as we were in the early 90s when everybody was focused on tuberculosis. And if you look globally, look at influenza transmission, look at MERS in Saudi Arabia, look at Ebola, and look at the spread of MDR-TB around the world. These are failures of infection control in healthcare facilities. So we're trying to leverage this crisis, like all other crises, to work on root system problems that will prevent not just Ebola, but everything else.
Gregg, you have something to add.
I love New York City, but you're an outlier. If you look at actually public health spending on the state level over the past 10 years, it's decayed in most, if not all, states. And so the idea that we have any sort of rational approach, we talk about the sort of irrationality and the fear and the panic and the paranoia, but if you don't want something like this to happen, or a measles outbreak, you don't disinvest in public health spending on the state level, and basically the trajectory is down, not up. And so, you know, is this a teachable moment for political leaders?
Okay. I think, yeah, okay, Rachel, maybe last question, and then I'll have a question for the panelists, yes.
Hi, Rachel Moreski, Mailman School's Sid Hart program, and also the fellowship director for the International Emergency Medicine Fellowship. We send a lot of emergency medicine fellows to NGOs to work in West Africa. We currently have 6 out there right now who are graduates of Mailman. One of the questions I have is, from each of your perspectives, what is the best use of a university to respond to this? Is it technical? Is it programming? How would you, what advice would you give us in terms of our effectiveness? Thanks.
Okay, I'll start with Jay.
I was going to think of my answer. That's a tough question. I would say, I mean, again, the focus of the outbreak is Africa. So I think the work, you know, looking at what Wafaa does in ICAP, I mean, the idea is that we already have people on the ground in these countries, or connections in these countries. And I think leveraging those connections to address the epidemic is probably, for a university at the scale of Columbia, which has, you know, tentacles in all sorts of places and community members that have been educated in those communities. I think really directing every aspect, because as we've discussed here a lot, it's not just health delivery, it's all aspects of the health system. So I would say, to the extent that you can convene and organize people across all of the disciplines, from members of the affected community to people who have research activities there, and leveraging them in some way to help, I think that's really where I think the benefit is going to be greatest. Again, our needs domestically are largely, I mean, these are things that need to be solved through government, and then through working with our mass communications and media. So I don't see the role of universities as critical as it is where the epidemic really lies.
So I'm going to modify your question a little bit, Rachel, and ask the rest. But what would you tell each individual in this audience? What can they do individually to confront this outbreak, both there and here, within their own community? So, Emmanuel, then I'll go that way. And we have students in the audience and people who are waiting to hear from all of you what they can do themselves.
I think I would treat it a little bit like a clinical algorithm. You can definitely do something, but then the first point of that question is like, are you interested in going to West Africa? And if yes, then there's a whole range of things, and we need people, you know, with a wide range of skills. Again, I found the people I got the most out of as colleagues working over there were anthropologists, you know, social researchers. There's a ton of things you can do on the technical side, on the data side, on the clinical side, on the research side. We've just got a grant to do research, not research on like a better PPE suit, but like research on why do people do, you know, what drives people to do some things or not others. So there's a ton. And then I think if you're here, there's a lot of things you can do. I mean, for clinicians, we've employed, for example, we have 3 clinicians working now to help us screen people going abroad, drawing up, you know, basic. So there's a lot of kind of prep work. It's like a space launch, you know. There's a lot of people who aren't in the actual, you know, rocket ship who are helping to make it happen. So there's a lot of those needs very concretely. And then, as I think Wafaa was implying, every person who comes and speaks well, you know, or speaks common sense, you know, in terms of the science, and tells people, I'm not scared. Like a friend of mine who's a complete hypochondriac, who has no connection to public health, but wrote to me at the beginning. He said, like, you know, I'd love to see you. You know, I don't believe you're infectious, and you know, no, but it was a lot for him to say that, and like he's saying it to other people. He's saying, like, you might not believe this from me, but I'm not panicking, and I don't think you should. So I think that can help. And the last thing for members of the Columbia community, going back to Gregg's point, I would really take action to ask why a university, which should be a beacon, is having a policy that clearly has no basis in science.
Thank you. Thank you. Gregg?
Look, I think when you get trapped at public health schools or medical schools, you think of methods and techniques and the technical stuff is your job, but it's not, okay? You gotta speak up. First it's at Columbia, but then you're in the seat of all this media and political power in the United States. Think of all the crazy shit that was coming out of CNN, Fox News, MSN, all of this stuff. You can challenge as public health and medical people and speak truth to power. And then you can go after Governor Cuomo and Governor Malloy and Governor Christie as well. But the point is that medicine and public health is not just a technical exercise. It's about politics, and it's about power, and it's about speaking up. We learned that from the AIDS epidemic. If we didn't act up, I'd be dead, right? We didn't act up, I'd be dead. And it's the same thing about MDR-TB, it's about Ebola. If we're gonna do this work together, you gotta get out of your comfort zone as students, as researchers and clinicians, and say, I'm gonna be a citizen of the United States, whatever country I'm from, and speak up and do your job as a citizen of the country you're born in, or the one that you came from.
Thank you. Imam Konate?
In terms of a technical, I would say if you are able to go to West Africa to help people there, in terms of programs, we will bring West Africa to you. How? There is a West Africans here from West Africa in general. How can we bring them to you? Any student, anybody, you're willing to come to the community, talk to people about these epidemics, Ebola and HIV/AIDS, by mobilizing, educating, informing them, we can make it possible. Throughout our houses of worship, you just coordinate with us and we will inform them. You will come and address the issue, whatever you can do. Also, it's not only that, because I know that the issue today in Liberia is that they are isolating the people who are affected with the Ebola. They don't even feed them. No food for them, they're sitting there by themselves. Anybody can provide any financial aids for these people to eat because the Ebola is there, he's affected and he's not eating. He's not gonna be able to live no longer. So they need our help here and over there. So our event, we invited the ambassador of Sierra Leone, ambassador of Liberia and Guinea. They all mentioned that anybody want to help, we want to provide any financial help. They are open, the doors are open for everybody. Please, they need help, they need food, and the government is not doing enough for these people. So we are human beings, we are creation of God. Let us come together and help our people back home in West Africa.
Thank you. Thank you very much. Well, I think we've had an interesting conversation and a very thought-provoking conversation. I hope that all of us here who've been here and will truly become activists, as Gregg and many of the other members of the team, of the panel have said earlier. We need to be agents of change in whatever sphere we function in. I think we need to stand up when something doesn't make sense and challenge it. We need to speak the evidence, and we need to keep pushing and pushing and pushing until someone does hear the evidence and is willing to do what needs to be done. It's not easy. Gregg, was it easy? No. No. I think each one of the panelists today is in a way an activist, and I hope that as we walk away from this event is that we are walking away with a plan in our own mind of how we're going to influence the response to the HIV epidemic, as well as, of course, in response to the Ebola outbreak in West Africa. So thank you all for being here today. And I, of course, want to thank especially our panelists, and including Sheri, who unfortunately couldn't be with us. And I want to acknowledge a few people who really helped make this happen: Catherine Boffolino, Melissa Reyes, and Alberto Mejia, and others who were very helpful in getting us all to this event and making it all a success. Thank you.